We've got a good number in, which is really good. Thanks everyone for joining. I'm just looking at the sort of participants. We've got a sort of mix of sort of friends we've made over the last 18 months and some new faces, which is kind of as it should be. For those who have not joined before, have only joined one or two, the background to this very simply is that during COVID, we stood up some what were weekly and then fortnightly seminars to quickly, if we could, crash data together about COVID and to try and highlight lots of really good practice that we saw, which was very, very wide ranging from kind of people, sort of amateurs at home who'd managed to scrape a load of regional websites, some local newspapers who'd done some amazing stuff, some local councils who had some very useful mapping applications. We've had some stuff down from Kent, where myself and Nigel were from. We did a piece on domestic abuse, which was really interesting and quite bold in terms of IG. And actually at 2 o'clock today, there is a call I'm on in another region where they have watched this, taken the approach that we did in Kent, and want to try and make some brave IG decisions about linking data from the police and the NHS together to target domestic abuse. So if it achieves nothing else, apart from one of my sort of pet interests, which is domestic abuse, it's been really successful. Paul's team have sort of stood up the technology, and we're really grateful for that. And through a kind of rag bag of networks, we've managed to get some really good speakers together. It's all there on the website. If you've missed any that you're particularly interested, please do go back and have a look. So we've reduced the frequency of these, and we want to kind of go sort of deeper into a few particular topics. So the last time we had one on information governance, because it's so sensitive, so the GPDPR debate, and we tried to get some different views across the kind of political spectrum on data sharing, which was really good. I think one of the best sessions we've ever done. Paul and I have been talking for probably a year about starting to do work on mental health. Part of the serendipity of this getting back together was we both hit 50 and got back together, caught COVID, and have seen each other more than we might have done in the past. And we joke about kind of men's mental health weekends, whether they're, still trying to dance around. I'm going to see Fatboy Slim tonight, actually. So whether you can still move around a bit or just get together. And so mental health is something we've been aiming to get to for a while. We've got two really good speakers. So thank you to Sebastian and Nigel for taking us through your slides in advance. I'm just going to ask Paul first to do a bit of an update on where we've got to as Open Data Saves Lives. Lots going on. We've got a couple of sponsors in. We've got some ideas for projects. But Paul, if you take over for 7 or 8 minutes, then we'll go to Sebastian.
Yeah, can you hear me?
Yeah, loud and clear.
Perfect. Can you see my screen?
I can.
Yeah, so this is Open Data Saves Lives. If you find us at opendatasaveslives.org, that's great. Mark's nicked a lot of what I was going to talk about, but basically, hopefully you know where we've come from. And we're now a non-profit initiative. So Mark's doing data for good in Kent with beautiful information. We're Open Innovations, used to be over the Icd, doing open innovation with data for good with a mission up here in Leeds. This is now an initiative, if you like, because we've got sponsors. So we have TPP and SCW who are sponsors, and we've got a supporter in the Health Foundation who are supporting the events program. And that means we can do stuff like we did our events, our unconference last month, which if you look at the events on the page here, you can see our unconference. And we've got all of the great speakers, all of the updates here. So please have a look and look at that. And we've also got all of the talks we've had previously all written up. And the support from the Health Foundation means we can start to be a bit more planning. There's a bit more planning around this. And it's also about how if you like, if you're doing complexity science, how an emergent thing starts to evolve. And we're amplifying the things that have been most successful, hence the GP DPR work we did, and there's going to be more work on that. But also the conversation around mental health. So mental health is a really important issue, but we've been talking to NHS Digital for a while about how they structure their data, how they might share it. effectively, how other people might share it. It's a massively broad issue. So we've come to the decision that actually we can't do it in a one-off. You know, we're not going to do this in 45 minutes on Zoom across the country. So this is going to be a regular feature of our events for the foreseeing future, maybe for 6 months. We'll see how it goes. But we're going to ask people to talk about data and mental health and how it can help over a longer period. So next month, we've got NHS Digital, who talked at the Unconference about their data structure and how they're going to share data. I know Chris is on the call today. He'll be listening to what we're talking about today. And the NHS Digital are going to talk next month about their progress on their route to publishing more data related to mental health, which we hope can be incorporated in lots of different services in different ways that we don't know yet. And we can give feedback in an informal way to NHS Digital without a long discovery process. Online here, the people who are doing the work can get some rapid feedback and do something that can make a difference. So that's a short piece around there. But then just to feedback on what Open Data Saves Lives is going to be doing in the near future. So 2021, if you like, 2020, we were rushing around, doing loads of stuff, being responsive. That's emerged during 2021. So from September, we're a thing. We have a website, and we almost have board meetings now, which we're starting to get involved with. We're going to be doing some innovation work with our sponsors, so TPP and SCW. We're going to be asking you to give us data. We're going to innovate with it and give it back to you. And then we'll talk about that at the sessions in 2022. And the events program will be working with people we've talked with before, but once a month, probably a little bit more deeper dive into issues that are really important with the regular mental health issue for the next 6 months. But the thing I want to make sure that people understand is that we're going to be doing our events, we're going to be doing innovation, we're going to be sharing data, code, and documents, and we're going to be trying to kill reports for everyone, so things are on the web. But we're going to be doing it on at pace. So one of the things we are really aware of is that the real success of Open Data Saves Lives when it started was how fast we were, how quick we were able to respond, how great it was to have the people doing some of the best work available every week, every 2 weeks, to talk about their work and create ripples, which we're now responding to. So Mark is talking to some people who want to do the partner violence data governance, and we haven't had to have many conference calls. They've seen our work on the web, they've looked at it, they've reached out, and we're going to share back to them. And we've got numerous examples of that happening. So we want to create more of that. And also encourage people to build websites, not write reports. Use the web as it was intended. So I've got it there, Mark. You can tick off your Open Data Saves Lives bingo card for that. So the last thing I want to say is, if other people like TPP or SCW or the Health Foundation would like to use our model to do more stuff, please get in touch. If you would like to come and talk, or you think there's a subject we want to talk about at our events, which then could lead into a project, which then could lead into some data or code or a website, using this as a place to talk out loud about it, get some idea around your thoughts in a friendly manner with lots of people who want to help, please join in with what we're doing. So I'm going to hand back to you, Mark, and listen to the next talks. Thank you.
Thanks, Paul. Okay, we're spot on for time. So we've got two great speakers, Sebastian from the Health Foundation first, then Nigel. Sebastian, go for it. If you want to share your screen and take control, if you've got slides.
Sorry, can everyone see that?
Yeah, got it fine.
Brilliant. Okay, so hi everyone, thanks for having me here today. My name is Seb and I'm a data analyst with the Health Foundation. I work mostly with the Network Data Lab, and this year I've been spending most of my time on children and young people's mental health. So I've been spending a lot of time with mental health open data, which is, I guess, what brought me here today. I'll be giving a short talk on a mental health data set called MHSDS, and I'll be telling you about how the data is collected, what's in it, and kind of the good and the bad of working with it, including some neat workarounds that make it easier to work with. Okay, so I think a good place to start is if I explain kind of what the data set is and where the data is coming from. So within the NHS in England, you can get mental health support from a few different places. So you can get support from your GP, and they're usually the first port of call, and they deal with most of the prescriptions for adults. You can also be referred or refer yourself to a service called IAPT. So this is for talking therapies, mostly for depression and anxiety. And finally, you have specialist mental health services, which covers a pretty big range of things. So from community mental health to inpatient care. So the people that provide mental health treatment are, for the most part, NHS trusts, local authorities, the independent sector, so private care, and also care trusts. And anything that is at least partially funded by the NHS, they have an obligation to report their data to NHS Digital so that it can be included in data sets like MHSDS. So it's a bit confusing because IAPT, so the talking therapies side of things, is not included in MHSDS. It has its own data set that lives somewhere else. So providers submit data to NHS Digital, who then do a huge amount of work cleaning and processing it, and it gets packaged into what is essentially an NHS data product called MHSDS. So what happens next? NHS Digital sends the data back to the desk rows and the CCGs, who use it for research and commissioning purposes. But they also publish a lot of it on the NHS Digital website. So they publish monthly reports, which is what most of us are using when we want to find out, you know, how many people are in contact with the service and that sort of thing. So those reports are published as CSV files and spreadsheets, and they're kind of like sprinkled all over the website, which is fine for most audiences. But if you're someone like me or someone like probably some other people on this call who need to look at this sort of data very often, it's just not really ideal. So you might just be wondering, so what's in this data set? There's dozens of variables, but the key ones are the number of people in contact with mental health services, the number of new referrals each month, how many people have had their first contact each month, how many people are staying in wards, how many people, for example, have been sectioned, and much more. Some of the things that are missing from these monthly releases are how long you have to wait to access treatment, and also the size of the waiting list. So that's the sort of thing we'd like to see going forward. Okay. Also, just very quickly, so why does it matter so much to have this data out there openly? It matters because, as we know, waiting times to get seen by a specialist mental health service are very long at the moment. And there's also a kind of postcode lottery system as well, with some parts of the country just doing a lot worse than others. And these are just some of the recent headlines. So as you can see, the pandemic has had a big impact on some people's mental health and on the way the NHS is delivering those services. So being able to access this data is really, really important. Okay, to sum up, MHSDS comes with high quality statistics, very transparent metadata on how everything is computed. They also publish really in-depth data quality reports every month. So that tells you which providers are contributing data each month. And it's also updated every month, which is great because it gives you really timely data. However, what's missing is that there's no kind of place where all of the historical data is in a single file or in a single location. So if you want to do things like time series analysis, you have to get a bit creative to get around this. So for example, if they had an API like the ONS have for a lot of their data, then that would be really fantastic. So yeah, in the absence of that, what we've been doing is the following, and I'll try not to get too technical because I know we don't have that much time, but basically we wrote an R script that goes and web scrapes the NHS digital website. So it starts with the MHSDS landing page. So that's the kind of like laptop you see at the left. And it scans the page and all of the sub pages looking for all of those monthly files that I just referred to. So it's not always easy because the files aren't always where you expect them to be. And they're not always labeled the way you think they will. But in the end, it does work because there is kind of a logic to it. You just have to spend quite a bit of time trying to unpick that. So, for example, the code looks for all CSV files that have the words July or August or September, that have the title eating disorders and MHSDS, and that have the expected number of columns and that sort of thing. So after the code runs and fetches all of those data files, it does some kind of basic cleaning and saves the appended data set somewhere local on your drive. And we also added some features so that when you run it, it doesn't just re-download everything. It checks what you already have, and it only adds the new files. So ideally, you should only have to do it once a month. Okay, another way of looking at it is that you're basically taking apart the NHS website and looking for patterns in the HTML, and you write an R script that goes and retrieve things for you. And what's quite nice is that once you've done that, it really opens up the sort of analysis that you can do with the data, because all of a sudden you have time series, which you didn't have before. And so this is the sort of thing you can do. For example, my colleagues and I have been working on some reports recently that look at how mental health services switched to online consultations after COVID started. And there's a lot more that you can do. So just to wrap up, I can hear you asking, can I do the same thing for other NHS data series or even ONS data? And the answer is yes. So other people have done it, for example, for the A&E data, for the maternity data, and I've published all of my code on GitHub. So I can post a link in the chat, and feel free to fork the repository and do the same thing for whatever data set you're working on. Because we know that looking for hundreds of CSV files on an NHS website can be pretty tedious. So as I showed today, there's another way of doing things. Yeah, so I think that's it from me today. Thank you so much for having me. And if you have any questions, just feel free to reach out either by Twitter or email or here today. Thank you very much.
Thanks a lot, Seb. Really interesting. I'd partly for my early onset dementia, I've typed my questions into the chat, but just reflecting, it might be worth, I'll see if other people have got direct questions for you, but it might be worth, we can do Nigel's session, and then between you might kind of field, because mine are quite general, so they're kind of probably as much for Nigel as for you. And I'd kind of be interested in your views on them. Can people shout out if they've got specific questions for Seb? So I've got one here, actually, I've got one from Rory in the chat. Have you tried approaching NHSD direct instead of, trying to do what you're doing at the moment, which is quite creative?
Yeah, so we've been in touch with NHS Digital, but I think so if they end up sending us the file, that helps us, but it doesn't really help anyone else. So ideally, we'd like them to publish it on the website.
Yeah.
And at least with this approach, other people can go ahead and replicate that.
Yeah. Okay. Paul's asked you, as he would, to do a guest post, so we'll sort of put you on spot. I'm sure we'll hoover up any sort of links and things that you do on the slides. But if you're able to write something, a side or two of A4, just longhand, we can publish that amount of text as well, which would be great. Any more direct questions for Seb? Otherwise, I think what we might do is go to Nigel, but then come back to some of the. I had some quite specific questions about linked data sets, and Nigel will know this from us working together in Kent, but also I'm interested in the IG around mental health because obviously it's slightly more sensitive.
Mark, it's Paul here. I'm just
yeah,
making
go
a
for it,
point
Paul.
for Seb.
Yeah, go for it.
I think the people you need to speak to will be speaking at Open Data Sales Live next month because they're the product owners for NHS digital mental health data. So I think this is brilliant because I think they were doing quite a they've been doing some discovery work. But if we can just shortcut some of that discovery work and show them what's needed to help you build your product, I think we can show a massive positive for Open Data Sales Live here. So if you want to join us next, well, obviously we've recorded this. We'll share that with the team at NHS Digital who are coming next month. But they're going to join us next month. So if you join and ask the questions, we'll put the people using data with the people publishing it together. And we could have shortcut a lot of discovery phase works. And we've killed some reports, hopefully. So yeah, and actually done some stuff. So that's amazing. Brilliant stuff.
Thanks, Paul.
Yeah, thank you. Thanks again, Seb. Okay, Nigel. I don't think you've got slides, Nigel. So Seb, if you want to stop sharing, that's it. Brilliant. Sorry, I've got a hand up now that I've got my screen back. Sorry, David, I overlooked your question. Go for it.
Yeah, sorry, I was just going to jump in and say you was talking there about NHS Digital turning up next week. I'm kind of part of the mental health team at NHS Digital, so we are hearing this now, just to throw that in there. We're kind of aware of some of these issues around time series and that we need to try and get it out there. Some of the difficulty of it is around the structure of the data set, how big the publication is, how much of kind of some of the mechanisms for submission of mental health data mean that the time series data is difficult to you'd have to reproduce it each month. So there's kind of technical issues behind it, but it is definitely something that's around and on the radar.
Yeah, I mean, I think part of what Paul and I tried to put together is a rag bag of people that might be able to help. So if there's anything we've got, or we know a bloke down the road who has got a bit of, if we can help, David, just shout. You and Paul happen to both be in Leeds anyway, so you're not even leaving.
So I think it is literally some of the mechanisms and things like that that we're working through, to be honest. It's something that takes time as well, as much as anything.
Sure. Yeah. If any of this network can help, just give us all a shout. Okay, Nigel, over to you.
No problem. Can you hear me okay?
Yeah, loud and clear.
Brilliant. Okay, so yeah, thanks very much for the invite this afternoon. I'm quite new to exactly what you're getting up to here, but all sounds very, very exciting and keen to show a bit more interest in the future. I guess by way of background about myself, so I'm currently Assistant Director of Information and Performance at Kent and Medway Partnership Trust, which is one of the largest mental health trusts in the country. So we've got a big geographical area. I've worked in the organisation for over 14 years now in a few different roles. So I've sort of lived and breathed the data development in the trust, and I guess the national picture as well from when I started, which was a few sort of Excel tables and a few graphs published once a quarter, into everything we do now, and obviously building on what Seb's just spoke about, which I'll also touch upon large aspects of the MHSDS, the flows of data. So what I'll do, I'll run through, just a bit of an overview about sort of, I guess, a provider's view of the national picture, a bit of context about what we do locally outside of that national picture. I'm not really sure of what everyone's background is on the call, so I will keep it quite generic and welcome any questions at the end, and can pick up those other ones which are in the chat already. So I think overall, I mean, it's, for me personally, it's quite an exciting time for mental health data. Obviously, it's come really up the radar over the last decade or so, increasing sort of more funding and a greater, use of data to really get into the detail of some of it. So it's good that it's on the up. It's definitely in a much better place than it was, but I do think it's a huge area of untapped potential, both within the mental health sector and looking wider afield, how we can sort of work with other aspects of health, social care and beyond as to how we can utilise some of this data. So I think what we've had in the past is quite a unstructured approach. The MHSDS has existed for a long time, but I think it has for many years, but as I say, improving year on year, been a bit of a sort of black hole as to where we go into all these tables going up every month, actually by means of that data being played back to us by local commissioners or any regulator or anything like that, has been really limited over the years. It's sort of there's been times in the past where it has been used a fair bit more, back in the days of the monitor frameworks and things like that, but increasingly it's been very targeted on a few key issues, despite the whole wealth of information which is going up. So I think there's also something in about, I think there's been lots of local approaches around the country of how people have set data up over the years. Obviously, the MHSDS has always been there. There's been things like benchmarking in lots of different forms, and most recent being the NHS benchmarking, all good, really powerful tools. But actually having that one data set, which is that sort of one version of the truth, which is recognised nationally, I think is something which still we struggle with from topic to topic sometimes. So I guess against that background, as I say, we are one of the larger trusts. There's about 60 in England, more in Scotland, Wales, Northern Ireland. And as I say, that is really focused on secondary care mental health. So obviously we've got the IAP providers, primary care, third sector and things like that. And again, from a sharing perspective, it is quite limited at this stage. And I know some of the questions, so I'm sure we'll get into that in a bit more detail as we go through. So I think, picking up on the MHSDS, building on Seb's presentation. So I think there's something in it for me at the moment is, it's largely focused on completeness as opposed to effective, I guess, use of interpretation analysis in the vast majority of cases. I think there are exceptions, and I should say as a provider, we haven't had a CAMS service for quite some time, and obviously some of the slides there which we just looked at reference CAMS, and they have got a bit more of that structure where there's been a bit more development of the thinking as to what that sort of patient pathway looks like and how the data maps to it so it can be used effectively. I'll touch upon early intervention in psychosis, which is probably a good example where I have been involved, where similar sort of strides have been made and where it really shows the benefits. I think underpinning all of this, just to bring people's attention to, is sort of consistency of terminology and setup across trusts. As I say, there's, across different trusts, we've all got different things within our portfolios. So especially when we're comparing trust level data, sometimes it can be a little bit misleading, because what may sit in primary care in one area may be very much within secondary care in another area. And then even when you get to the layer below that, what is a community mental health team? I mean, I think if we got into that detail as we do to a point for some of the benchmarking exercises, we've all got different things within our community mental health teams. Some people still use things like an assertive outreach approach and primary care link workers up until the EIP development. That was a big change for some people. We'd already separated out our early intervention teams, whereas other trusts hadn't. So again, it just underpins that fact that even when you think you're looking at data, what is representing those high level figures sometimes has got a long history which we need to unpick before we can draw any strong conclusions from there. So I think there's something in the ability to, start with some of this high level, someone is open to secondary care mental health, that tells us so much, but that sort of drill down in the detail, I guess it's very much work in progress and differs from topic to topic. So all the different specialties across mental health setting are at slightly different stages based on national priorities and things like that. I think some of the things which have worked well around beds, beds are easier to count than some of these community settings. An acute bed, a psychiatric intensive care bed is generally not open to much debate. They are what they are. And obviously from a sort of, they're a high proportion of the cost, even though they're a low proportion of everything secondary care mental health does. And obviously the main priority for us at the moment, some of you may be aware within the 5-year forward view, is the reduction of external placements. So there is some very good use of things like the MHSDS and other data sources around these very high profile things which are built into clear I guess strategy, and the monitoring's wrapped around it in a way which we're all comfortable with working with. And I touched upon early intervention and psychosis, so probably similar to the CAMS work, which I haven't been so involved in, but it's a good example of how it can work. Lots of national reference groups. I sat on a few of them, real joint partnership work between the clinical leads and the data leads to really work through what that clinical pathway should look like, how we can map, data from a provider perspective, working with NHS Digital and everyone else that was involved to really make sure all the system changes were made, understood and rolled out consistently. And that's where we have got good, robust sort of waiting times that we can use, and I think people generally stand behind that data. So when that time and effort is put in, and it was quite labour intensive and it did take some time, it has resulted in good, effective use of data, and that is still developing, but beyond the waiting time, looking at consistent outcome measures and really starting to make some judgments as to what kind of patient interventions using SNOMED codes are really starting to make a difference for that sort of key patient population. And I think the intention with some of that is, I think many years ago there was the intention to sort of rattle through 20 or so different standards like that. And as I say, I know CAMS has done that, and there's other good examples, but it has stalled, not just because of COVID, but also pre-COVID. But I think there's a bit more appetite now, and some some recent communications sort of saying we're really starting to nationally think about the national waiting times for mental health, because they don't exist in a mandated measure, in the exception of some of the things we've talked around BIP. So that's a brief overview of like sort of national picture, but I guess what's plugged that gap in the meantime is very much a commissioner provider led discussion over the years, which has created lots of
You're just frozen
local data sets across the country, which am I back now?
Right, you're back.
Yeah. I'm getting a message, my internet connection's unstable, so hopefully that passes. So I was just saying the local sort of flavour has grown over the last decade or so of meeting local needs with local data sets, taking into account some of those variables about different setups. I think also in there we've had a few attempts and never got anywhere nationally with sort of a payment by results type mechanism. So those of you that may be aware, we tried using a sort of outcome measure called HONOS, informing a cluster, but I think it was complex, it didn't take nationally, and I think some of that has sort of harmed engagement over the years for people's buy-in to the effective use of data. I think that there was maybe some mixed messages in there between the clinical benefits of using the data effectively that way, and obviously then the costing element which went over the top of it. And I think, against that background, what we've had is this sort of, minimal cause and effect of, I guess, for want of a better word, good data. It is lots of data being produced, but the consequence and things like that of good use has been left to local determinants. So what we're really trying to do now is shift that approach. So, really trying to use the data more effectively from a clinical pathways and decision-making tool, really trying to change some of that culture and build up some of that buy-in to the potential of what we've got at our fingertips. Obviously, that requires the data quality elements to be addressed, but really getting clinical leads on board to really push some of this through, whilst we keep an eye really on what the national picture is, which is emerging, because we do expect more sort of national measures to come down the pipeline as more funding comes into mental health, and that's a clear intention. There's some early work around the community mental health framework, which could be a quite significant redesign of our services, which will change things again. So I would like to see, the considerations of those data flows into MHSDS and the data quality and consistency of, what we all call certain types of activity to really be taken into account as we go through that process. So that's, as I say, sort of a brief overview. So I think just to summarise from my perspective, really, there is an increase in focus. There's huge untapped potential, I think, in the data sets we hold if we can get it right. I think we start small and build into the depth of detail. The cultural work about, the use of mental health data and the importance of it is obviously the most important thing, more so than any sort of technical response we come up with what we do with that data at this moment in time. There's work to do to define what good looks like in a consistent way that can be rolled out nationally, so we're all comparing apples with apples. And then obviously beyond that, as we can build on that journey, some of the work which we've started in Kent through some of the work Mark's mentioned, but actually then once we can do that, trying to triangulate that information more with other health sectors and see what other value we can add. So I'll pause there and happy to take any questions. I can see some chats flying through, so I'm sure you've got on them, Mark.
Yeah. I'll sort of line them up for you, so you're not trying to do two things at the same time. Well, I'm interested in, for both of you, what impact the COPE notice might have had. So in the acute setting, it really helped us crack on. We could kind of link data more quickly, stand up COVID databases, get into NHS Digital, get vaccine data more quick, and so on. And it was quite helpful. I wonder what impact COPE had for both of you in your respective roles as the first one.
From my perspective, I don't think it had a great impact. Obviously, we weren't so much in the firing line of the data needs during COVID. There have been obviously, things like vaccination records and things like that. It has helped open doors a little bit to start some of those conversations a bit more easier. But again, I think the sort of the requirements on ourselves to the need to do things differently, to come up with new answers, I don't think are in the same sphere as I know what you guys go through with regards to the requests aren't hitting us. So we're not reacting to those questions in quite the same way, which has led us to use that significantly. Yeah, it's interesting. You'd wonder. We've done stuff in the past about take up of the vaccine by different ethnic groups, for example. If you found out that everyone who didn't have a vaccine also had a particular mental health condition, that feels like it's a really important fact to know and that we might address. So I think the sort of follow-up, and Sebastian, come in if you want on some of this, I think the linking in of your data to kind of the wider determinants of health that you talked about, Nigel, one of the things that I'm about, and Abraham, George and others, is can we link your data to data from the council, from social care and so on? Do you think we're going to make progress on that? And acknowledging that mental health data is quite sensitive, but you would assume that a lot of the drivers of mental health problems are not NHS data sets. They're about housing and family structure and education and lifestyle. And how are you sort of getting on there? I think it's more on an ad hoc basis traditionally, working with the likes of Abraham and others over the years. Obviously, we're trying to take a more centralised approach now through the work which you're leading on. But yeah, it's been very much ad hoc. I think, not necessarily outside of the health sector into social care directly, but one area which is a good example is physical health checks. What we know about people with long-term mental health conditions and the impact due to various factors, including the medication which they're on, the impact on their physical health check, and obviously that being a QOF register target, there's some, that's a real area of investigation of how we share data effectively to make sure, both from a patient perspective really, that we're not giving them a physical health check when they come to visit secondary mental care and they had one the day before in the GP surgery. So how we can use data more effectively across that sort of platform to make sure patients are getting a physical health check, and it's equitable that someone isn't getting two and someone else isn't getting any type thing, so to make sure we can use that intelligence. So there's a few examples like that, but I think again we're quite reactive, where the way if we take the vaccinations, for example, a lot of that data is held externally for us, and we're more the receivers of questions to help interrogate it, as opposed to needing to use the data in quite the same way, I think.
Yeah. Sebastian, what do you, as someone sort of from the centre, as it were, and, trying to get access to rich and richer data all the time, have you felt that, does it feel as though things have got easier because of COVID, that people kind of believe that, linking data up and sharing it in this way is good, acknowledging that mental health data is always sensitive?
Yeah, I can echo what Nigel just said, where a lot of these linkages are happening on an ad hoc basis. So what I'm working on day to day is the Network Data Lab, and that's a Health Foundation program.
Yeah.
We have 5 partners, so including Leeds, Liverpool, Wirral, Northwest London, Grampian up in Scotland, and Public Health Wales. What we've been doing this year is linking MHSDS to those other data sets. So that's things like some employment data from the council, social care, adverse childhood events. So it is happening on an ad hoc basis, and keep your eyes open, because we'll have some nice reports coming out early next year.
Yeah, that would be great. And I was going to ask about timing, actually. That would be really good to get the Health Foundation to come back on some of that early next year.
We'd be happy to.
Yeah, that would be brilliant. We've kind of got, because you've got quite a mixed, it might always be the case, but we've got quite a mixed economy almost in terms of policy, because you've got kind of got people at the centre saying, you need to do pop health, you need to link data. You've also got alongside them NHS Digital saying, proceed with caution. You've got local IG groups that are, vary massively in their level of risk and appetite. So we, as a kind of collective lobby group, we're trying to make the case that, that data for good, open data saves lives, however you want to kind of caricature it. So it would be great to see some of that when we come back, because it just makes it easier for us. If Nigel and I are in Kent and we're going, the Health Foundation have done this over here, this was the IG framework, this is how they did the infrastructure, this is how they set up a trusted research environment if they needed to, and so on. And we're just trying to, amongst other things, we're just trying to collect lots and lots of good examples of best practice so that other people can do them. So the domestic abuse call this afternoon is probably easier because someone else has done it. Someone has opened a door, and then others are kind of going through it. Okay, I'm conscious of time. Because we always try and give you 10 or 15 minutes back. Rowena, thanks for your plug, and thanks for offering to come back and present that. There's some good work going on at University of York, which we'll see next year, which is good. Any kind of last minute questions? I had some technical stuff which I might probably just pick offline with Nigel. When I was at Dr. Foster years ago, we tried to analyse the mental health minimum data set, and that concept of a spell, an episode and a spell and a super spell, is relatively straightforward in an acute setting, is much, much more complicated in a mental health setting. And I just wondered if that felt, given over your sort of 14 years, Nigel, does it feel like that's becoming easier? And then allied to that, I had a specific question about use of Snomed and Icd-10, and where you are up to on that, because in the other conversations we're having in Kent, we've got GPs that predominantly run read codes for diagnoses, and in hospitals we're running ICD-10 codes while looking at a move to Snomed. And I just wondered, I haven't looked at mental health data for a while. I just wondered where we're up to on that, if that's all right, Nigel, last couple of minutes.
Yeah, so on the first point around spells and that, I think what we're seeing is maybe years ago, as I say, we talked about mental health spells. I think the questions are a lot more targeted around what's happening in EIP, what's happening in this aspect of the service in crisis response, for example. So I don't think it's progressed a great deal, but I think we're almost naturally moving away from it rather than seeing that entirety of, and I think that's sometimes a challenge, as in, mental health is, has been in the past sort of seen as that one spell, but actually when you break down what's going on with the patients between inpatient stays, crisis responses and psychology interventions and things like that. So I think what we've done is refine the questions over the years, that actually we're not looking at entirety of spell a lot of the time. We're looking at what do we know about patients that go through this aspect of a service, would be my sort of general feel in the direction of travel.
And on the Snomed CT, where are you up to there?
So on diagnosis, we still use ICD-10 for our inpatients only. We don't have coding as such for our community patients. That's a relatively small proportion of our work. Snomed, we had a sequence a few years back around sort of our contacts applying Snomeds to our day-to-day interventions in the community, which was light touch, shall we say. It was, mapping a defined list to, to each intervention. So yes, it was using Snomed, and from a, it's a good example, I guess, in some ways. We've got data quality and maturity index, of which Snomed completely is on there and we score highly against, but actually it's the depth of information there to really allow us, what I want to get to is those Snomed interventions overlaid against outcome measures, for example, and we truly start to understand what type of interventions are having the biggest impact on our patients. But what we've actually got is, out of the, I'm not sure what the number is these days, 5,000 odd Snomed codes, if not more, we're actually only, returning 30 or so, and we're revisiting that. I think that sequence came to an end just pre-COVID, and it's another thing which we always had the plan to get through the sequence part of it and then build upon, and obviously the last 18 months has seen priorities go elsewhere. But we at our trust data quality group this week, actually, we were having exactly that conversation about how do we pick this back up, and how do we drive forward using Snomed in that perspective. And I think as part of that discussion, the link to Snomed for diagnosis will also be picked up, because we've got the functionality in our system to allow us to do it, but it's not sort of embedded in processes and policy and monitoring in order to really see that through. So that's a bit of an emerging picture.
Yeah, really interesting. And we should try and pick some of that up regionally, because as you know, I'm just trying to get everyone to align recording standards, clinical coding standards, so it all just links up much more easily. Thank you for that. Not Poppy, yes, we'll publish all of this, and with links on the web and on Twitter and so on. Let's finish up. Paul, can you just give us the date for the next one, as a mini plug, and then we can close down.
Oh, I think it's the 8th of December. Grace, is that right? I'll just put Grace on the spot there.
Hi, it's Ross. It's the 9th.
Oh, Ross. Yeah, thanks, right. So the 9th of December.
I'll post the link on here.
Yeah, great. Brilliant. If you want to, the 9th. Okay. So in there will be, it looks like we're going to have the NHS Digital's team talking about their mental health. I think a bit of a technical talk about how they're going to publish data, but also how people can feed in use cases to the team so that they're working on real use cases. So I think this is going to be really useful for them, and we can all follow their progress next year, which should be, be fantastic. We're going to have myself and Mark are going to talk about what we're going to be doing next year. And I think we've got a confirmed talk from the Open Innovations team and Magpie Communications Agency, where there's a great example of using the published open data by PHE to target vaccine interventions on harder to reach populations. So we're going to go and share that, and we'll do an example. So lots of really great stuff coming. Please join in and share. And I think we've got, we usually get about 60 people. I think we've got nearly that this time. Please share that with your colleagues. And also I think that this is a safe place for nerds to come and talk about high quality data stuff and examples. And if it does one thing, which is to short circuit the number of meetings we have to go to, the number of reports we have to write, and we actually get to work on real projects and with real data, would be a huge help for all of us. So thanks for joining. And now I think we can close off. Yeah,
brilliant. Thanks, Paul. Thanks, Sebastian. Thanks, Nigel. We'll write it all up. We'll come back to all of you with the links and the recording and the dates for the next session. So we'll see you there. Take care, everyone. Have a good rest of the day.
Cheers.